I'm going to start my session on patient assessment. So these are my disclosures, because we have to have these here. And there's a disclaimer. Okay, we've done those. And here are our learning objectives for today. We're going to discuss, really, the key thing we're all looking at is expanding the role of nurses in rheumatology in Asia and look at rheumatology practice. We're going to look at some pathophysiology and explain the social and some of the psychological impacts of RA, and look at some of the issues about diagnostic criteria and differential diagnosis. And that's important for us to understand as nurses as we extend our roles. And then we are also going to look at some of the different measures of disease activity for RA and discuss some of the issues about comorbidity and their impact on screening and management. And really, all of that is talking about how we assess all of these issues and understand them when we're managing patients in our clinical practice. So, the role of the nurse in rheumatology. There are many factors that have led to the development of rheumatology nursing. The challenges are sometimes very difficult political and professional challenges, as well as just the educational challenges. But for us, now is a golden opportunity because your expertise, your knowledge is going to make a big difference for the future. We have better opportunities now for professional education. We have new opportunities for specializing in fields. I know it's more of a challenge in Asia, and sometimes it's about nurse managers and your hospital authorities recognizing your expertise and using it appropriately. But we have good opportunities now to try and optimize that. And the most important thing we're all very aware of is the big demands of our healthcare system. We have more and more people living longer and longer, and although we live longer, which is great, we don't always necessarily live better lives. We have much more comorbidities, much more problems with our health, and as a result, there are big demands on the healthcare system. And equally, as we have learned more and more about rheumatology, we understand more about how we can improve patient care, and the person that's really in a very good position to provide a lot of that support is the nurse. And when you look at lots of studies about how patients feel with their disease, rheumatology nurses are in a very good place to help those unmet needs at the moment. Patients' expectations when they go to clinic are often very emotional. They're very anxious. They've got physical symptoms and signs. They're worried about what it means. They don't understand about the treatments, and they're frightened of them, and they need some feedback and understanding. Those are the patient's needs. And we are ideally placed because as caregivers on the wards and everything we've done in the past means that this is our role. This is what we're used to doing on the wards, and we can extend that and improve that. So we're able, with our knowledge, to give much more treatment education. We're able to assess the patient in the context of their disease, and we'll talk about more of that as I go through. And we're able to interact with the patient and provide the feedback as a result of the treatment they're on, so they're understanding and reassured on their journey through healthcare. And when you look at RA and you look at the needs to develop the rheumatology services and care, you can see that this big paradigm shift, this shift in rheumatoid arthritis being not just about them coming to clinic and getting a few drugs to help some of their symptoms, we are actually now looking at a much more targeted approach. And you're going to hear a lot about treating the patient to target now. It's a big shift from just helping their symptoms and hoping things will get better to really saying we are going to reduce this disease to the lowest possible level we can. And as a result, we need to increase monitoring if we're going to do that. We need to make sure that it's a coordinated approach to managing the care with the rest of the team. And we need to make sure that we're evaluating patient outcomes all the time. And all I can say is we have lots of evidence and many more sessions I hope we can deliver. And today's touching really all of these topics briefly. But systematic reviews in Europe have shown and demonstrated the value of the nurse specialist role. We've proved with very good research over and over again that nurses are an incredibly valuable resource. And these research projects have shown that nurses are as safe as junior doctors. They're in delivering care when they're trained appropriately. They provide patient education. They are able to deliver drug and disease monitoring and conduct clinical assessments and make referrals effectively. And those are exciting pieces of research for us to have to discuss with our colleagues, our rheumatology colleagues, who will be nervous about nurse developments because they will feel that this is difficult. How can they trust you? How do they know that you're good enough? And this evidence is vital for us to be able to do that and help you explain to your doctors. So I was involved in this work and I worked in EULAR for a long time, and I'm very excited about some of the key papers that have come out on the recommendations for the role of the nurse. And this is the role of the nurse in chronic inflammatory arthritis, which includes, of course, rheumatoid arthritis. And we developed these recommendations because we were aware from the patient's perspective that they really wanted access to nursing education much more than they were getting. And they needed access to a nurse consultation, dedicated time with the nurse to understand how to improve their disease and make them feel reassured. And the nurse-led clinics and nurse-led telephone support provide that continuity of care, that ongoing care. Because if you look at many clinics in many countries, a patient may one day see one doctor, the next time they come they see another junior doctor, the next time they come they see somebody else, and they think, well, the first doctor I saw knew all about it, and this doctor I have to explain it all over again. Where nurses understand that and they have that full continuity of care with those patients. So nurses should, if they're going to undertake these sorts of roles, must really participate in a comprehensive disease assessment. And we know about holistic assessment. We know it's not just about, if you like, the medical model of saying this is the disease. We know that psychosocial issues, we know other issues come into the management. So we undertake this comprehensive disease assessment to understand the patient's needs as well, and address their social and psychological issues, which are often great barriers to them wanting to have treatment. And by doing this, we are also going to promote their self-management skills and enhance their ability to manage their disease themselves. And if I want you to take away one big message, it's remember that we need to foster patients not being self-reliant on the healthcare system, but being more able to self-manage themselves so that they know what to do a lot of the time. They don't have to keep worrying about next time I go to clinic, but feel they've got some tools to manage their disease themselves. We also need to do this work, and we need to be mindful that we are developing an expertise, and we need to do this using protocols and guidelines, as we call it in the UK, our framework for practice. That is how, as a nurse, we have the way we should work, and we collect the protocols and guidelines for that. So we also need to ourselves undertake continuous education so that we're up to date and always moving along as developments happen in rheumatology. And equally, we should remember that we are also on a journey in educating the patient. You don't just educate the patient once. The patient's needs will be continuous too. Their needs, educational needs, will vary, but they will be different every time they come to you, and they might be ready to learn things where they weren't ready to learn them before. We really should encourage ourselves to take on these extended roles and become specialised, because it is key to optimising healthcare provision. We need to make sure that when patients come, it's a very effective experience for them in healthcare. We cannot afford not to be effective when patients come to the hospital. We need to make sure that we're delivering good care, evidence-based, in protocols, appropriately documented, so that they are getting the best they can and we're using healthcare resources effectively. So it's part of a comprehensive disease assessment. And I'm really excited to see that the Chinese national nursing policy on this is about developing advanced practice, and I know it's a challenge in developing advanced practice, and I don't know how to say, that Mrs. Yun, who's with us today, is part of the Chinese Nursing Association, and it's very nice to see that we are looking within that in China to building a specialty nursing accreditation system that's developing well, I think. And rheumatology, we're just trying to get there all the time. And we need to expand the roles at community level as well, so patients have support in the community. And we need to develop, and this is really key, we need to develop a real career pathway. If we want more good nurses like you all sitting in this room to come into nursing and to stay in nursing and to be rheumatology nurses, we have to have a good career ladder. We have to feel there's some target that we want to go to for our professional development. And so having a good career ladder system is really important. So part of the key things we're talking about here is about, and I've mentioned them already, conducting systematic collection and documentation and validation of what we're doing and how we do it. We're going to support the patient in their diagnosis. We're going to facilitate shared decision making. Now, shared decision making is a term a lot of people use very loosely, but actually shared decision making, we could do a whole day's session on shared decision making. But we actually need to make sure that shared decision making is part of what we deliver when we work with the patient. And because we need to ensure that each patient's management and care and assessment is individualized to that patient. And that takes quite a lot of skills. And here are some of the fundamental principles of those skills and the way we have to use them. And these take quite a bit of time to explain. I'll try and do it not too long because time is of the essence today. So we know as nurses we're very good at being very patient focused, but when these are the fundamental principles of nursing, to be patient focused. But in nursing and in specialist nursing it has to be a dynamic process because every time the patient comes to you things will change and we need to be able to change and assess what the patient's needs are at that time. It needs to be interactive so that I am learning as much from the patient that's sitting opposite me as they are learning from me. So it is sharing. So the patient will give me information that will help me understand more about what their needs are, and I will then in turn share what I understand back. And it's a very interactive process with the patient. And importantly, and I think this is very important when you become a specialist nurse, that you need to be structured and clearly documenting your interventions and what you do with patients. And the process should include observation, data collection, and validation, and clinical judgment, really using your expertise to understand how and the best way forward for that patient. And you will use multiple data sources for that. And all of this will facilitate a good clinical decision-making process and an evaluation of the care you're going to give. And I've developed these sort of slides over time with one of the things I find in my experience of going around the world and helping nurses develop their clinics is we all learn as ward nurses, and sometimes what happens is that we haven't got the skills to know how to structure our consultations. But this is just talking about different ways that you can see the patient and how you need to think about them. And the patient will come in through the journey as an admission, a first visit. What can you do? What can you do to support that patient? How do you do it? And it's providing this nurse consultation, performing the assessments, providing the education, and looking at the interventions and the monitoring you can undertake. So it's, and as a result of that, you develop an action plan and you share that with the patient so the patient knows what's happening next. It's very scary if you think about it. If you don't know what's happening next, you need to know the next steps in your care. And this is just setting this out. Now, this is how I teach nurses to start their own clinics. When the patient comes in, they have a particular agenda. That's, if you look here, this tiny thing doesn't work really well. This is, I'm going to trot over here. Back here. This is the patient's agenda. This is so tiny you can barely see it. The patient comes with all sorts of concerns when they come to clinic. Those are the things they want to know about their illness, what should they expect, all of those things. And what we need to do is make the patient comfortable, explain what you're going to do in the time you have with them, and then tell them what I have to do is I have to do a DAS score, I have to look at your blood results, but I want to know what you're anxious about, and we will make sure we cover that in this clinic appointment. And then we gather the information together, then we share the information with the patient, and we conduct the assessments, and then at the end of that we share together the understanding of the assessment we've undertaken, and then talk about the next plan. So that's how a nurse consultation works as far as I see it. So the key takeaway messages from this little section that I've been talking about is really that we want the role of the nurse to be evolving and continue to evolve, and it has evolved over time in Europe especially, and I'm really excited about the next steps in Asia. And biologic therapies have made a huge difference and a huge demand on services. They are fantastic drugs, but we have to be able to deliver them safely and monitor and manage them well. Nurses are increasingly recognised as playing an important role in rheumatology, and we need to come up to that and provide good care educationally ourselves and for the patient. And there are common barriers to implementing nurse-led clinics and time constraints and lack of resources. And those are challenges that shouldn't stop us. We need to find ways to work forward, and we need good career pathways. So I hope that is just a flavour of where we're going. And now I'm going to give you an overview, just a refresher, because I think many of you will be very conversant with all of this. And we're going to talk about the pathophysiology of RA. So there are multiple risk factors, as you know, for the occurrence of RA that increase your risk of having RA. As you know, there's genetic susceptibility, the fact that nearly all of us women here have a higher risk of having rheumatoid arthritis, and those will affect things. And there are epigenetic factors. That is that you're predisposed. You will have a genetic factor, but you'll also have an epigenetic factor where your tissues are predisposed to switching over from tolerance and normal immunity to autoimmune disease. And there are other environmental factors that we know do affect the outcome of RA, particularly smoking, for instance, and other exposure to other aspects of harm to you that may change your outcome in RA. And there are multiple risk factors that contribute to the outcome, how well you're going to do with your RA. And there are, then again, the age that you present with RA will define whether you will have such an aggressive disease or not. Late onset, late presentation is associated with joint erosions at presentation, is associated with a poorer outcome. Inflammation and how high the inflammatory markers are, your gender again, which we've talked about, and environmental factors, and of course disparities and inequalities in disease management. And that's key to what we're talking about today. Some patients are going to do a lot worse because they don't have access to the right healthcare provision and support. So when we look at this, when we put these things together, that genetic susceptibility, that epigenetic risk, and the environmental factors, that little group of things, that little triad of things, suddenly can change in a person, and the body starts to translate and change from having a normal immune system to an autoimmune system, where your body suddenly recognizes your own tissues as foreign, and you start damaging your own tissues because they think they're foreign. A bit like when you have a flu bug. Your flu bug, you have to fight that off with your own immune system. And when you have rheumatoid arthritis sets in, the body has examined and said, these tissues don't look like they belong to me, I'll attack them. And this then develops with the damage that initially patients aren't aware of, and then they become symptomatic, and that's when they come to see somebody and get help. So this is a result of the autoimmune reaction, and we know that these autoantibodies will attack the healthy tissues within the body, and these antibodies we know as ACPA and rheumatoid factor, and we know that these two measures are very important in us understanding autoimmune disease with rheumatoid arthritis, and they are important indicators for us, and they show that the level of disease and damage in the synovium that lines all the joints, And we know that these are pro-inflammatory markers, and they, as a result of getting active, they increase the inflammatory mechanism in the body. And it's a bit like, I explain it as a bit like a firework. It's an inflammatory cascade. This autoimmune system starts firing off chemical messengers, a bit like hormones. Cytokine and their messengers are a bit like hormones. They then start other actions going on, and this firework of inflammation starts. And in fact, pro-inflammatory cytokines can lead to this articular damage and also non-articular damage that we see. And both rheumatoid factor and ACPA levels can be reduced with effective treatment, and that's what we're looking at. We need to bring down those inflammatory processes. So if we look at inflammation at the tissue level, we know we see synovitis, which is very common in the first presentation in ultrasound. If many of you have looked at ultrasound, you can see how hot the joint is with all that inflammation going on. And then this inflammatory cascade, which involves leukocytes, it involves macrophages and T and B cells, and this inflammatory cascade, then these chemical messengers, these cytokines and chemokines, and of course now we know JAK intercellular signaling, all cause the cytokines to continue the for inflammation effect. And that just becomes more and more damaging to the joints, from the joints point of view, but also extra-articularly. And then this picture here, if we look at this picture, this on this side, the left-hand side as I'm looking at it, is a normal joint, and the synovium is normal there. And if we look at this side, you can see that there are many inflammatory cells here. All of these have the ability to perpetuate, to increase the inflammatory markers. And so they are talking to each other with these little cytokine messages, increasing their response. And it's really like an inflammatory soup, this side. And here you can see the proliferation of the synovium, and the mast cells, and the lining becomes thicker, and you get the pannus formation that we see in patients. And that's the inflammatory cascade that we want to damp down. And this is a bit more of a complicated side. I wish I had time to tell you a little bit more about it. But when we're talking, is this working? Yeah, you can see can you see the tiny red dot? If you look at this, some of these treatments we're talking about, this is a macrophage, and these little bits here are receptors on the macrophage. And here is a cytokine coming in and connecting to receptors. And that is really where treatments are. They are blocking the ability, once that receptor locks in, once that cytokine, locks into the receptor, that is where an inflammatory action starts. And the treatments that we have are blocking anti-TNF. Where's TNF? I can't see it on this slide at the moment. Anti-TNF, for instance, we are blocking the ability for that cytokine to lock into that receptor, because once the cytokine locks into the receptor, that's when more inflammation happens. So that's where our treatments are working. So we could do a whole day on this. It's fascinating, it's complicated. You need to understand some of it. You don't need to understand all of it, so don't be too worried about all of that. But it's an important factor for us to understand. So when we think about rheumatoid arthritis and we think about that patient presenting with all of those problems and then actually coming to clinic, we have to think, and we need to be much more mindful of the patient coming in. I think when you're very busy in clinic, you don't always think about the cost to the health system and the challenges that we've got in seeing patients, and also the cost to that individual person as a result of their disease. So we talk about direct costs and indirect costs. And direct costs are these costs which the health authority and the government are very aware of. These are things that have to be funded: inpatients, outpatient costs, doctors' costs, nurses' costs, medication costs. All of these are direct costs. And then there's indirect costs. And if you think about one family who've got somebody that's got rheumatoid arthritis, a man of, say, 40, we're going to do some case studies, but a man of about 40 who's got 3 or 4 children and his wife doesn't work, and he now gets rheumatoid arthritis, and his job is using his hands. What are going to be the costs to their lives? It's significant. And in different countries, it will have a different impact, because sometimes there are benefits and help by the government, and sometimes there aren't. And sometimes people have to look at all sorts of really difficult situations when they're that ill. So we need, when we're thinking about these patients that come in, we need to be really mindful and supportive of the challenges they have in their life, you know, and the psychological impact is huge too. If you're a man and you've been used to earning money and managing your family and feel proud that you're providing for your family, and then you cannot, your self-esteem is affected and your belief in yourself, and you become depressed if you lose your job because of it. We know that from a lot of research, that depression follows loss of job. And we all say we'd like some time off, but actually jobs are important too. But it does affect the psychological aspects. So there are big costs associated with rheumatoid arthritis. So my key takeaway messages from this little section is that RA is a chronic autoimmune inflammatory disease, and we have lots of risk factors for the occurrence of rheumatoid arthritis, as you know, and we need to be mindful and understand those, and that the autoimmune reaction affects the healthy tissues, both within the joint and extra-articular as well. And I think I've explained to you just briefly the complex interaction in the inflammatory process with these cytokines and chemokines and the tissues that are damaged as a result of this, what we call upregulation of that is for inflammation cells. And the management of RA, we really need to ensure that we have a very good holistic approach, taking into account not only the articular effects of the disease, but the extra-articular comorbidities and psychosocial effects as well. So we're now going to just talk about diagnosis and differential diagnosis. And these, again, we could do a whole day on most of these little sessions, but we're touching briefly on all of these topics in a way that I hope we can build on in the future. So when we talk about diagnosis, now, I'd just like to say it's important to say, because I've been doing a lot of work on developing nurses across the world, and when I put up sort of slides like this in a nursing talk, the doctors say, why do nurses need to know about diagnosis? Well, we do need to know. It's not that we are necessarily diagnosing ourselves and expecting to take over the role of the doctor. It's that we are diagnosing to help the clinical decision making and help the support, and also because we are another pair of eyes and ears, educated eyes and ears of the team. Understanding diagnosis and differential diagnosis is important because we might see something in clinic that the doctor hasn't seen, and it's part of sharing. And as time goes by and you become much more skilled and develop nurse-led clinics, and some of you are doing that, that actually your consultants will say, well, my nurse specialist really, she can diagnose quite a lot of the patients. You know, you learn an awful lot through doing this regularly. But it isn't a very easy process in rheumatoid arthritis. It's a mix of things that will help the diagnosis. So it's your patient history, it's the laboratory investigations, it's a good physical examination, it's imaging studies. Some of those will help. But a lot of it is about the patient's history, their family history, the pattern of the disease. So you will be looking and you will know well already, all of you, what commonly presents with rheumatoid arthritis and how it presented. Did it come on suddenly or quickly? The level of morning stiffness they have. The site and distribution you'll be looking at very carefully. You'll be looking at the joints to try and see if it's symmetrical or asymmetrical. And you'll assess that and look at that tissue swelling that you'll be examining for. And the onset and whether it was acute or not. And you'll document these sorts of issues in looking at the patient's history. And other factors that might help with a differential diagnosis. For instance, if they've had a serious infection, if they have other comorbidities, you want to look at those and collect the data on those. And you want to look at their history of diseases or chronic illnesses, you know, whether they've had cancer or other environmental factors that might impact on that, and of course family history. And then of course what you want to do is look at the impact of the disease. For instance, I did a fascinating video when patients were on biologics, and patients have still a lot of functional problems with their hands. And so I did a video where we timed a patient taking off a shirt and me taking off a shirt. I had clothes underneath, taking off a shirt and seeing how quickly, you know, a patient can do it. And everything takes longer when you have rheumatoid arthritis, even when you're a lot better. So things like that have a lot of issues for the patient. And also the wider issues that we don't always assess, looking at things from their functional point of view, how their feet are, can they walk okay, do they need aids? All of those things are important to look at when you're assessing the patient. So we know, looking at the most common musculoskeletal characteristics, that these are the things we're looking at to define whether it's rheumatoid arthritis. We know it's polyarthritis, many joints are involved. They're usually large and small joints in rheumatoid arthritis. They're often peripheral joints, hands, feet, and they can be upper or lower limb. In AS, you see much more of an oligo, that's one joint involvement, that's 5 joints or less. Tends to be larger joints and tends to be more central presentation, so the spine, SI joints, and tends to be lower. So often the hips, the SI joints are painful, the spine's painful. Gout, of course, is a different presentation. It's asymmetrical. You see lots of the smaller joints, large and small joints, but lots of the PIPs rather than the DIPs involved. Peripheral again, but it can be upper and lower. But again, you're looking at what else would you look at? Uric acid, those sorts of things to then define that patient. And psoriatic arthritis, I think, is the one that often is a challenge when you first have see patients, because they have monoarthritis often when they first present, but when they've got more aggressive disease, you can see something that almost looks like rheumatoid, but it's large and small joints again, it's peripheral again, and it can be lower or upper. But there are some other classic signs that would tell you, wouldn't they? So skin involvement, nail involvement, things like the sausage finger that we see. So those are the things you'd be looking for to define the difference. So when you're thinking about rheumatoid arthritis and you're thinking about assessing the patients more widely, not just from their rheumatoid arthritis point of view, you'll be looking at their skin, and the classic thing is rheumatoid nodules. But you also need to look at their history. For instance, skin cancer is one of the common comorbidities, and skin cancer in the Western countries is growing faster than any other disease. It's very high prevalence now. I'm not sure about Asia, to tell you the truth. You'll be looking at their cardiovascular system and understanding whether they have any hypertension, heart failure, ischemic heart disease, because those are going to be very important when you're looking at the drugs they're going to be on. So you have to examine and understand that, and that's what you need to know when you see patients, exactly where they are with those things. And again, the pulmonary system, lots of involvement there for people, and lots of things you need to think about: pleural thickening, pleural effusions, pneumonitis, nodules on the lungs. Luckily now we have biologics, we don't see so much of these, thankfully, and we're getting patients to be seen earlier. And again, these poor patients have lots of eye problems, and of course we see common comorbidities with cataracts because we have a growing elderly population, and they're very commonly presented in older patients. So we need to understand about eye things, particularly when we're thinking about putting patients on hydroxychloroquine. Nervous system, again, we see lots of involvement in the more aggressive disease over the long term, where there's been a lot of damage with cervical problems, and we need to check and understand if they have any other comorbidities, particularly demyelination disease, because those are things we need to think about when people are on anti-TNF. And of course, very importantly, we'll be looking at their blood picture very carefully and finding out if they have any abnormalities in their blood picture, because that's going to be vital for our long-term management. And then kidneys. We're going to be looking at what kidney function they have, because, again, many of the drugs are excreted through the kidneys, and we need to be mindful of that and know if there are any risks from renal failure, because if patients are not excreting the drug so well, then the drug levels in their body will be higher and they'll develop more toxicity. And then we're looking, of course, at other skeletal issues, and one of the biggest risks for our patients is osteoporosis, particularly because they will have had steroids and they're not so mobile. So an awful lot of things to think about, really, when you look at it. And these are the things, your skills in the clinic are supporting the rest of the team in identifying and looking at, but also vital for you when you're looking at your monitoring of patients. You need to understand how the cardiac things will affect your blood monitoring. You need to understand if this patient is going to be safe to go on a biologic. So there are lots of things to think about here. So we also, I'm not going to be talking too much about this because I know Gladys' session is going to be covering this a lot. So there are many laboratory tests that we will be doing and you will get used to. There's rheumatoid factor, of course, which used to be the gold standard, but has really been replaced by ACPA now, which is a much stronger, much more sensitive tool. And we talk about sensitivity and specificity. And the tool for ACPA is it's much more sensitive because it identifies more patients who have rheumatoid arthritis. Rheumatoid factor doesn't identify as many patients who are positive for rheumatoid factor as ACPA does. So ACPA is a very good measure. And rheumatoid factor and ACPA are really important indicators in the beginning of a patient's presentation because they will actually tell us really how high their inflammatory processes are when they first come to us. ESR and CRP, in the UK we generally use CRP. It's a slightly more expensive blood test, but it is better than ESR because an ESR will say be raised in many situations. So if you've had a cold, your ESR will be up, but if you've had a cold, your CRP won't be up quite so much. So we need to be aware of those limitations in ESR if we're using ESR. And if you're using ESR with a DAS score, you must always continue to use ESR because it will change between the DAS, between the ESR and the CRP. We want to look at the complete blood count, particularly things like neutrophils where they may well be affected as a result of drug treatment. And we need to look at comprehensive metabolic assessments. So we need to look at their electrolyte level and their renal function to make sure we understand those and their baseline. And one of the key things I think that's important to take away if you're starting to do nurse-led clinics is not everybody is average. So the average, the normal range of bloods, sometimes somebody will never have had a normal range of white cell count. And you see those patients, and you must be learning about your patients on a regular basis because you will see a trend in the blood levels. And if you don't know, if they're always low, and then you see them for the first time low, and you'll think, oh, I must tell the doctor they've got to stop treatment, and they've always been low, that's what they run at. So it's actually being really knowledgeable about the patient and their normal blood picture. And then, of course, there's synovial fluid analysis. Generally, we would be doing that for two reasons, wouldn't we? We would be looking for infection in case a person had an infected joint, and we'd be doing it for things like to exclude things like gout. So those are a wide range of tests that we need to get, if you like, better at really getting knowledgeable with understanding what they mean and what implications it has for the patient, and of course with their comorbidities. So that takeaway message is that nursing assessment is integral in this. We need the structured consultation process, we need to understand the diagnostic criteria, and we need to understand the difference between these different types of inflammatory disease such as gout, osteoarthritis, psoriatic arthritis, when we're looking at diagnostic processes. And now I'm just going to be talking to you about clinical assessment of the disease. So how do we make that clinical assessment in clinic? And we know that when patients present, they present with active disease. And disease activity and the inflammatory disease process, which we've just looked at a little while ago, in those very, very early phases, that is reversible. If we get the patient fast enough, we can reverse the disease activity. We can stop the damage to the tissues and the joints. But that dotted line is really important because that needs to be done quickly, and we're going to be talking about treat to target in a minute. But if we leave it too long and the patient leaves it too long, which is one of our challenges to come, they will end up with joint damage and as a result disability. And that, once they've got the joint damage, we can't reverse that. That's irreversible. We're stuck with that. So there's a good reason why we need to be looking at getting the patients as soon as we can and doing the best we can for them when we see it. So disease activity is very different from disease severity. So disease activity is what you see when you assess the patient, what is reversible and what is the process going on at the time you examine them. And you're looking at the disease progression, and you're looking at representing the target of symptomatic treatment. Disease severity is the impact of the disease, and that's the impact to the person and the symptoms. And you must measure both of those to understand what you need to be doing for a patient. So you're looking at the disease activity and you're looking at the disease severity. And patients may vary, and you may have two patients with exactly the same DAS, and one person, or disease assessment score, one person will be doing really quite well, and the same person with the same score might be doing very badly. And that's an interesting thing to talk about. So disease activity is, assessing disease activity is really important in the treat to target approach, which we're going to be just briefly touching on now. Ultimately, what we're trying to achieve for the new world of managing rheumatoid arthritis, and this is a big ask in Asia because of the challenges of changing services and redesigning services, we want to achieve remission for as many patients as possible. Remission is the no signs of active disease in the patient, and that's a very big, exciting new target. And if we see them early enough, we can achieve remission. For some patients who've presented late or have very, very aggressive disease, we will have to review whether we can achieve remission. We will aim for remission, but we might actually have to accept that we're going to low disease activity. Okay, so we will aim for that if we can. And we will be doing that in what we call the window of opportunity, which is the first 12 weeks from disease onset. Now remember that some patients might not come to us in the first 12 weeks of when their disease starts, and that's a big challenge for us for the future. But that's what we need to be thinking about all the time. We want to get that patient managed as quickly and aggressively as possible. And as we've said, disease activity, there is no particular one measure that's going to tell us how active their disease is. It's a number of tools that we will use, and that's assessing the tender joints, the swollen joints, and it's what we call a composite measure. You put some of the patient's aspects of the disease into a score with some of the objective measures of tender and swollen joints, and that is called a composite score. And it's like the DAS-28 is a composite score. And we will be looking at those and putting it together to measure the disease. And I don't know if many of you have seen this slide before, the treat to target approach. Have any of you seen this before? Hands up. Anybody seen this? One or two? Okay, right, but this is the new world. This is really, really exciting. The aim is that patients will attend, and their main issue with those patients when they attend is to treat them to target. And what we mean by that there's very strong evidence behind this, and we can look at it all. It's been done in diabetes, it's been done in cardiovascular disease. Here is rheumatology doing it. And treat to target means that we have objective measures that we use frequently to set a target to ensure that the patient has the lowest disease activity possible. And we will do that by starting their treatment early. So we will see the patient, and very quickly we will be trying to set up their treatment and then modify it by seeing them. Ideally, in Europe, we say every 6 weeks, but here it's set for 1 to 3 months. And in APLA, I think it says 1 to 3 months, to see them every 1 to 3 months. And if they're not improving and achieving their goal, we keep changing their treatment, adding in treatment, to make sure that we're trying our best to get their disease activity down. If we can, we're aiming for this remission, and if we have to, we may have to modify it and review it for low disease activity and look at an alternative target. And the therapy, modify the therapy regularly until we get to 6 months, and we would hope we might actually have achieved some remission. If we haven't, we keep on. But if we achieve remission or low disease activity, we then review them every 6 months to make sure that they stay well targeted and well managed. Does that make sense to everyone? Yeah, good. Okay, so these are some of the tools that can be used. And on this side, here, these are the tools we talked about, the composite scores. The DAS28 is the one in Europe that we have used the longest and the best, and is well validated. We know its good points and its bad points. And so this is one of them. The problem is for the DAS is you need a blood test. And in some countries, having the blood test on the day you do the assessment is a challenge. And in other countries, it isn't. But that's why the CDI has been developed, which is, again, well validated. And you can do that without a blood test, and it gives you a score. The SDI is the same, but you need the blood test. So it's another tool that's been developed. So really, what you need to know is what tool you use in your department and how it's measured, and get to really understand those measurements. And then with that, those are the disease activity tools, and this side are the outcome measure tools of disease activity, which are patient reported. So this is the PAS, patient reported activity scale, and patient activity scale 2 and rapid 3. These are all very similar if you look at them. They're asking patients about what they can and can't do, and they score it, and they give a score about whether I can do it a little bit, not very well, can't do it at all, okay? And then those scores are added up, and some of these are very simple to look at, and they're useful in clinic, because if you look at how they filled it in without even scoring it, without even scoring it, you will see how many problems they're having. You can do the score, which is objective and useful for research, but even in the clinic you can look at those tools and say, oh, I can see you're having a problem with these things, which is really helpful for us. Now, the key message here is, here are these tools, okay, that we've just talked about, and they have set goals for what remission means. So in the DAS28, remission means a score below 2.6, okay? But in the CDI, it means remission equals 2.8, SDI 3.3. So you need to understand, whichever tool you're using in your clinic, you need to understand what these measures mean. Remission, low disease activity, moderate and high. Okay, you need to understand them and know how to act upon them, because they're your targets. And I don't know how many of you are regularly doing DAS at the moment, but the DAS28, here is an example, and these are on the internet, these calculators, you can get one easily. So what you would do is you would assess the patient, and you'd put in how many swollen, tender joint counts here, you put in how many swollen here, you'd put their CRP in, and then this is the visual analog scale for general health, and this is the patient-reported aspect of the scale, and this is, just to you remember this is heavily weighted in analysis for this part of the score. So that makes a big difference to the overall score. And you'll see here that it's calculated, and there is the DAS score of 5.2. So we need more work to do for that patient. But that's how we use these tools. So the key takeaway messages really are that disease activity is defined as a reversible inflammatory disease. We can do better in reducing the pain, swelling and stiffness, and get that treat to target approach. And we need to really work hard on this. This is the new world. This is the exciting bit that you are now all going to be knowing much more about. And we need to understand the patient outcome measures well. So the comorbidities, I'm just going to briefly touch upon these because I talked too long. So comorbidities that we need to think about when we're looking at patients. The patient first presents with RA, and as things emerge, as we've talked about with their inflammatory processes, they will have more damage in these areas. And we know this one is fascinating because we know continual inflammatory processes do a lot of damage to the arterial walls, similar to in diabetes and cardiovascular disease itself. And then they will develop other comorbidities, interstitial lung disease, osteoporosis, cardiovascular disease, which is a big, big factor in rheumatoid arthritis. And then they become advanced clinical diseases that they will have cognitive decline, functional decline, and organ failure, and of course, multiple problems with joints. And those are the real issues we need to think about. We need to keep them as low as we can with their presenting symptoms here, so we don't develop all of these other problems in the comorbidities. So when we're thinking about this, we need to think about the morbidity or mortality, how they impact on that person individually and their quality of life. We need to understand how to evaluate and to take into account the comorbidities when we're looking at treating them for their window of opportunity. And we need to manage them based upon evidence-based guidelines. So again, the treat to target thing now, the update on treat to target based upon the issues about comorbidity is that they have now built this in, and it's a really important factor on treat to target. We've all learned a lot in the early days of treat to target, is that we must consider comorbidities because there will be challenges in treating to target. If patients have renal impairment, have liver impairment, how are you going to be really aggressive with their treatment? So those things need to be taken into account when we're managing patients on treat to target. So my key takeaway messages are for you to think about here is that extra-articular effects of RA will overlap with certain comorbidities, and the effect of aging is an important thing we need to think about. In Japan, a few days ago, I was talking to the nurses, and they were very worried because they have the oldest population, and now they have a lot of patients with rheumatoid arthritis with Alzheimer's. How do you manage them was their question, a big challenge. But the aging population will add to this big burden, and there's a big demographic shift, and we need to be really aware of that for the future and find ways to optimize our nursing expertise to manage these patients. And we need to do our work in a systematic evaluation of their comorbidities and consider it when we're making the assessment for their overall outcomes.